The other day, I was asked to provide a second opinion on a cardiac MRI study. The patient was a 57-year-old man who had an echocardiogram that showed unexplained right ventricular enlargement. The physician who interpreted the MRI study had concluded that the right ventricle was enlarged and that the right ventricular inferior and free walls were hypokinetic. He suggested the diagnosis of arrhythmogenic right ventricular dysplasia and recommended a cardiac CT to look for fat in the RV wall. The CT didn't show any fatty infiltration. Because the patient had no arrhythmias, no ECG abnormalities, and no family history of sudden death, the cardiologist was skeptical of the diagnosis of ARVD and asked for a second opinion on the cardiac MRI. So let's take a look at it. Here are some images. On the four-chamber view, up here, you can see that the right ventricle and right atrium are enlarged. There's a brief jet of tricuspid regurgitation in early systole, and RV systolic function looks pretty good. On the short axis images here, you can see why the primary reader might have thought there was inferior hypokinesis of the right ventricle. If we focus in on this image here or this image here, it actually looks dyskinetic to me. But sometimes through plane motion can cause a deceiving appearance, and that's the case here. When you look at the orthogonal view here, you can see the inferior wall clearly is contracting well. So what's going on here? Let's look at the quantification. You can see we've got good endocardial segmentation for both the left and right ventricle, and the RV ejection fraction is 45%. The primary reader got an RV ejection fraction of only 34%, probably due to bad segmentation. He probably had a problem at the base of the right ventricle. The nice thing about the segmentation done here is that it's fully automatic. And a really useful feature is that it can automatically determine the base of the right ventricle from the four-chamber view, where it is often easier to determine than on the short axis views. Let's take a look at that. So here you can see the base of the right ventricle defined on the various phases. On the basal slices, you can see only a portion of the right ventricular trace is being used, depending on whether the slice is inside or outside the right ventricle, as defined by this LV basal line here. The right ventricular end diastolic volume index is 129, which is severely enlarged. Yet the left ventricular ejection fraction and end diastolic volume index are normal. To my knowledge, there are only three things that give you asymmetric RV enlargement. Number one, there's diminished RV function, which is not the case here. Number two, there's a regurgitant valve lesion, either tricuspid or pulmonic regurgitation. Or number three, there's a left to right shunt, like an ASD, for example. We saw a brief puff of tricuspid regurgitation in the four-chamber view. It didn't look significant, but TR can be difficult to quantify just by looking at the jet. I don't recommend trying to do it that way. The easiest way to quantify tricuspid regurgitation is to calculate the regurgitant volume by subtracting the main pulmonary artery flow from the RV stroke volume. Unfortunately, the site didn't acquire any flow data. Another possibility is that there's a left to right shunt, like an atrial septal defect. That could also give you right atrial and right ventricular enlargement with a normal RV ejection fraction. Patients with substantial left to right shunts also have enlargement of their central pulmonary arteries. We do have pictures of those, which you can see here. Let me blow it up here, play it in a movie, and you can see how large the central pulmonary arteries are. It would be nice if we had flow measurements of the aorta and main pulmonary artery. We make them routinely in our practice. If the site had made those flow measurements, I suspect they would have found a left to right shunt and reached a different diagnosis. so please consider making it routine to measure flow in both the aorta and main pulmonary artery in all of your patients. I recommend measuring each at least twice to assess the reproducibility of the measurement. It's quick and easy to do, and it can help steer you to the right diagnosis. If you enjoyed this video, there are more at cardiacmri.com. Thank you.